Mobility Part 3. This is Martha Olson for Introduction to Nursing Concepts. As we look at the assessment, we have to think of the complications of bed rest and also of activity intolerance. Assessment includes many things, and these are just a couple of them to consider. As we look at the assessment of activity intolerance, how do we anticipate what our patient will do? Are they able to hold their head erect? Is their body symmetrical? Are they able to bend their knees slightly when getting up? Can your client sit up without being supported, or do they lean to the side because they're so weak? Can they safely get in and out of bed, or is there that risk for falling? Can they change position by themselves, or are they able to roll and help you? With range of motion, is it passive or active? If it's limited, why? Think of things like arthritis, maybe a previous fracture, fluid in their joint. And then with their gait, is it steady, or are they swaying or leaning? Are they shuffling their feet? With the assessment, we have to always think about how is the assessment on the client going to change if they're immobile. So we want to think about checking the lung sounds more, encouraging the incentive spirometer and the coughing and deep breathing, changing positions. With the metabolism, they're losing their appetite, they're anorexic because their mobility is slowing down, their GI system is slowing down, and all of that with the peristalsis causes them to not really have much of an appetite. They're not doing much, and the body feels and has a result of that. For the cardiovascular, big one to put a star by, because we know that deep vein thrombosis is a lot of risk, and with that it can become a PE that gets to the lungs. So we look at, what is going on, the edema, showing us that it's in the dependent places. Many of the patients I've cared for with cardiovascular problems as a result of immobility, it's a generalized edema, and it pools on the bottom side of their body as they lay supine, and so you will notice it around the buttocks, around the sacral area, the lower legs, and that edema is what we call generalized pitting and dependent. As we look at the contractures of muscles, what are we doing to help prevent those? The movement, using pillows and washcloths and things to support and change those extremities to prevent that. Our skin is a big problem. Are we keeping them hydrated, turning them off, keeping that skin so that it is not getting a stage 1 that breaks down and opens up? So we want to watch all of those, including the urine, making sure they don't develop a urinary tract infection as a result of stasis of the urine. So our complications of bed rest are many. A lot of things as nurses we can do to help prevent them and anticipate problems that they might have. These are just a few of the complications of bed rest. As you look at this list, think of which one is my priority. Which one am I most worried about happening because of airway, breathing, circulation with Maslow. Then we look at safety, and last getting to things that aren't as priority or are not as important for them. The benefits of bed rest, there are a few. We've talked the whole time about why we don't want people on bed rest, but it does decrease the cardiac workload. If I have a patient that's a new MI, the stress of walking and ambulation are too much for that heart muscle that's severely damaged. It increases O2 demand. So if some of your COPD patients or patients that have airway problems, bed rest or the benefits of resting might help. As we look at this woman that's pregnant, many of your women that are preterm labor, that are having contractions, need to be on bed rest to prevent the contractions from continuing. Some of them are to decrease body stress, which is short term. The duration of bed rest depends on the illness and injury and the prior state of health. If you go into it like this lady, very young and healthy, you're going to come out of it okay. It's the person that's older and debilitated with many other health problems that is going to probably suffer some consequences of that. When we look at activity intolerance, it takes us back to that oxygenation unit where we think about, how are they tolerating it? Do they get to the door and they're huffing and puffing and they have to sit down? Or are they just a little short of breath and they need maybe their oxygen turned up to, 2 or 3 liters? What type of work and exercise is causing that? Some patients just sitting in the chair, the ambulating or pivoting to the chair, causes activity intolerance. For other ones, it's when they go to physical therapy and they're put on an exercise bike or a treadmill. Are they short of breath even just with sitting or at rest? Simple tasks such as eating and moving in bed often result in fatigue, and those are concerning to us because they aren't putting forth a lot of mobility with that. For our activity intolerance, our pediatric considerations, increasing energy for a toddler, they need more sleep because they're growing. Our adolescent in puberty, it's a time of growth, and they also need more sleep and rest for the the growth hormones to come out of that pituitary and cause their body to do what it needs to do, growing. Our older adult, decreased maximum heart rate. Many of them, their heart rate slows down, but it isn't pumping effectively. And then the intensity of exercise is not as good as it used to be. They aren't able to exercise as long or as hard as they did before, simply because of changes that go with the aging system. Some of the nursing diagnoses we've been talking about that fit with this, again, prioritize. For me, as I look at this, I would say my number one is probably activity intolerance because it goes with airway. Comparing a couple of nursing diagnoses, our 39-year-old patient is non-compliant with diabetes. Admitted with a wound to her heel, her blood sugar's running high. She receives her dressing changed 3 times a day. She's very verbal to the staff, and she doesn't want to ambulate with the staff or physical therapy. She calls her family, and they bring in McDonald's and everything else she wants. When we look at the second patient, it's an older man that had a bilateral knee replacement yesterday. He's hooked up to morphine on a pain pump or a PCA pump. He still has maybe a couple of drains in his knee. He's sleepy. He's wearing his oxygen. His O2 sat is running at about 92% on 2 liters of nasal cannula. His vital signs are within normal limits, and his assessment is uneventful except that he has very diminished lung sounds. So as we look at these 2 very different patients, we know that the patients on both of them need to be up and out of bed. We need to make sure that we are supporting both of them. The non-compliant patient needs to ambulate because it's going to promote circulation, and the patient B is going to be more sleepy, but we need to at least sit him up and have him dangle and take some good deep breaths and maybe blow some of that anesthetic out to help, because he is getting the diminished lung sounds. As we look at planning, we think about what are the considerations for how old they are, what does their skin look like previously, what medications are they on, and then revise our nursing care plan as needed. As we look at implementation, our range of motion, we want to think about what patient can move and what type of exercise can they do. If they've had an orthopedic surgery, we definitely want to be asking the physical therapy or the orthopedic surgeon, what can they do? What should we be doing? How do we need to reposition them if we're not sure? As far as range of motion, a couple of ideas. Do it when their joints are most mobile, after a warm tub bath or after a bath where those joints are relaxed. We want to perform physical therapy supporting the joints. We don't just want to hold up the ankle by our hand and let that leg be unsupported. Range of motion should never cause pain. We should never force a joint beyond its capacity, so you stretch it until you feel that it's tight, but you don't overstretch. Many times we need to repeat the movement 5 times during a session to help promote range of motion with circulation. And as I said, hold the adjacent distal and proximal areas to support the joint. And if you need help, you would want to, have somebody in there to help you. If it's somebody that's heavy or you have questions about what you're doing. Lots of ideas in the nursing home and in long-term care. They use colorful scarves and beach balls. They're doing things from their wheelchairs in a circle down in the activity room to have fun and promote motion for many of our elderly in long-term care. So you're assisting the client who has extended bed rest to perform range of motion. You perform this exercise by number 4, providing support for the distal joints. Distal meaning further away from the joint that is being exercised. And we usually exercise or do range of motion the larger joints down to the smaller joints. So you would do the shoulder, you would do the elbow, you would do the wrist, and then you would do the fingers. As we look at the anti-embolism stockings, make sure you know how to measure and put them on appropriately. That is a very important nursing skill. Knee high versus thigh high, they are often abbreviated. The difference between these is what the doctor orders or what he feels is necessary. We want to make sure that our knee-high TEDs that come below the knee are not too tight, that they're constricting or like a rubber band that would actually cause more circulatory problems. Measuring them is important because if we don't get the right size, they can be constricting or they can be too big and loose where they're ineffective. We want to make sure that we don't ever roll down TED hose, especially the thigh-high TED hose. When people have really heavy upper thighs, it's easy for them to want to roll down, and that again causes more of a constriction like a rubber band around the upper leg than what we want. We usually where the TED hose are kept, they have a measuring device that you measure the widest width of the calf, and then the for the thigh-high TED hose from the inside down to the ankle, so that we get the right length. Our TED hose, the other name is thromboembolic device. Our purpose is to prevent the DVTs, prevent blood pooling in the legs, and it's kind of that triad again where we have that hypercoagulability. It wants to clot. Venous wall abnormalities, damage to the inside. Maybe they've had some kind of atherosclerosis where there's damage to the inside of the wall, and then the stasis is something we can do. Something about we can exercise, we can range of motion, we can SCDs and TED hose to prevent that blood from being in that lower extremity or pooling in that lower extremity. When we initiate the TED hose, again, we want to measure correctly. We want to make sure that we remove them at least 30 minutes every shift or every 8 hours. When I come on shift at 7 p.m., I take them off. I do my head-to-toe assessment. I leave the TED hose off until either the nursing assistant has helped me with the HS cares, wash the feet, lotion the legs, and reapplied them, or when I make my rounds with my meds, I put the TED hose back on at that time. If they get soiled, we typically wash them out in the sink, hang them to dry. They're very thin like pantyhose, and they dry very quickly. They're expensive to keep getting new ones for the patient. So we typically, if they get urine, feces, or blood on them, we wash them out so they can be reused. Who would not need TED hose? We would look at different patients. Obviously, they'd have to have an order to have that. Most of your surgicals will have an order for TED hose. What we want to be documenting is things like how they tolerate it, what the skin looks like underneath, do they have good circulation, and if TED hose are put on too snugly, they rub against the bottom or the top of the toes, and you can cause like reddened areas even to the top of the toes. It's important we take them off every shift, and we're looking to make sure that they aren't wrinkling. I've seen that around the ankles where they will crease and wrinkle, and they will actually have skin breakdown as a result of that. So what is the most important reason anti-embolytic stockings are used on patients? We want to think about B. Venous return to prevent that blood stasis is why we have TED hose ordered. SCDs or sequential compression devices. These are throwaway items. The part that goes around the leg is Velcro, and we put those on with orders from the doctor to help compress the veins to promote venous circulation. We can delegate this to a CNA to put them on, to take them off, because they're very external, and really the only thing that you can do wrong is if you have them too tight and it's going to squeeze too tight. I usually go in and check mine at least every shift, take them off, and we keep using them until either we get an order not to use them or until the patient is very ambulatory and they're promoting circulation, doing their own thing. So as we look at our last question, we look at a patient that's on prolonged bed rest following a stroke. During the assessment, the nurse is alert to the presence of warmth to that calf area. Warmth tells you they might have a blood clot because of the stasis, because of the prolonged bed rest that this patient has. So this is number 3. We'll move on and finish up the unit with number 4.